All right. Thank you, everybody. Welcome to the September 18th meeting of the Finance Technical Advisory Committee. This is an advisory committee to the Universal Healthcare Commission. I am Mary Franzen, Covered Strategies Manager at the Healthcare Authority. And just a reminder, if you are an FTAC member and we move you over and you see an invitation to become a panelist, please accept the invitation to become a panelist. And that also will be the case later on for the folks who are providing public comment. But before we get to any of that, I will turn this over to Ross, and Ross will call the meeting to order.
Thank you, Mary. Welcome, everyone. It is now 2:03, and I call the September 18th meeting of the Finance Technical Advisory Committee to order. As we mentioned at the July meeting, we're looking for an FTAC member to serve as FTAC lead. Pam and David had previously served as FTAC leads and had a huge hand in shaping the work that we do. And we, as folks know, David unfortunately departed the FTAC committee. And so now we are looking for a volunteer to serve as a lead for 1 year. And I wanted to see if anyone was interested in that. It's a very prestigious position. Lots of everyone will be, yeah, vying for your attention. Okay. If folks want to think about it more, have any questions, please feel free to reach out to us. We'll also work with the commission, and they will likely identify an FTAC lead to assist. So yeah, hopefully we can find a volunteer rather than a voluntold. So we'll continue working on that. But please, if you have any questions, feel free to reach out. We also have a new member with us today, Matthew Morrissey from the Department of Revenue. Matthew's filling in for Ian Doyle, and we're grateful to have him with us as we move into reimbursement and financing elements. I was told Matthew is traveling during this meeting and will provide a more thorough introduction when he's able to join us at the next meeting. So just wanted to let folks know and say thank you, Matthew, and look forward to hearing from you further at our next meeting. Next up is roll call. When I call on you, please unmute your microphone and let us know you're here, and we will mark you off. Christine Eibner.
Present.
Thank you. Eddie Rouser.
Eddie let us know he has a conflict today. He's going to join as he can.
Okay, perfect. Esther Lucero. Okay. Kai Young. Matthew Morrissey.
Present.
Thank you, Matthew. Pam McEwen.
Present.
Thank you, Pam. Robert Murray.
Present.
Thank you, Robert. Roger Gantz, who I also
He
believe
also
is
let us
not.
know, but I believe Esther has joined us. Esther?
Hi, everyone. Yes, I did.
Okay.
Hi, Esther. Thank you
I
so
just came from
much.
another meeting. Of course. Yeah.
No
Thanks.
problem. The meeting, yeah, game of hopping is real. So thank you for taking the time to join us today. Thank you, everyone. Please join me in turning to tab 2 to vote on the approval of the July meeting minutes. And those should be up on the screen for you. Is there any discussion of the minutes or proposed changes that folks have? Okay. Is there a motion to approve the minutes?
I move approval.
Thank you. Is there a second?
I second.
Thank you. All in favor say aye.
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 Any opposed? Motion is approved. Thank you very much. So the July meeting minutes are approved. And now I'll hand it back to Mary to lead public comment.
Thank you, Ross. Since the last meeting, we received 4 written public comments. They're in the packet. The comments touched on a number of topics, including recommendations for transitional solutions, concerns about the Medicare population being excluded from universal healthcare coverage, recommendations for potential analyses that could be conducted with the OIC proviso funding that we have coming in the next biennium, and recommendations to address both provider reimbursement and finance concurrently. Those are both pieces coming up in the work plan, key design elements, so recommendation to consider those at the same time. And before we go into the comments of the folks who signed up to speak today, I want to pause briefly to discuss the concern about the Medicare population from one of the written comments, and the concern about Medicare people being excluded. And I will invite FTAC members to jump in as I'm speaking or when I am done speaking. Back in 2023, FTAC presented a Medicare memo to the Commission with a number of options about how best to address Medicare in the universal healthcare system. And whenever we talk about eligibility and groups that are in the initial, coverage pool or not in the initial coverage pool, it's always a very thorny and difficult conversation because the Universal Healthcare Commission, the goal is to cover everyone. That's always been the goal. But in this memo and in other situations that have been considered, FTAC members agreed that it would involve Congress in securing a comprehensive waiver granted by CMS, and that's the ideal approach to enroll Medicare enrollees in a universal health care plan. They agreed also that pursuing that is not an effective use of resources at the time due to the considerable federal barriers that are in place. So the decision was made to focus on groups that were a little easier to bring into the universal system sooner. We just want to clear up the confusion, and we also want to make it very clear that the Medicare population is not being left out. The Commission has not closed the door on Medicare enrollees, but keeping the initial eligibility discussions to groups with potentially less significant federal barriers. And this will come up again later. We're going to talk about the eligibility straw proposal and other straw proposals later today. So I don't know if any FTAC members want to jump in and add to what I just said before we go to the folks who have signed up. And also, it looks as though Kai has joined us, so great. Make a note of that. If there are no FTAC comments, we will go to the folks who emailed us and signed up. I am not sure. We had two people sign up. The first is Ton Smith McQueen. I don't know if Ton is here. Let me take a look.
Not seeing Ton. We do have Rachel, though.
Okay. Then the next person who signed up is Rachel Snell. So Rachel, when you get the invitation to be a panelist, please accept it. And that always takes a few seconds, and there's always a few seconds where we can't hear you and you can't hear us. So let us know when you're there. Rachel, you may still be muted. Hold on.
Oh, yeah, sorry.
Oh, there you are.
I thought it was somebody else before me. Sorry. All right. Wait. Hello, members of FTAC. I am Rachel Snell. During the tragic school shooting in Lewiston, Maine, Speaker Mike Johnson implied that the issue was the human heart, which is another way of describing a mental health crisis. This is too hypocritical, since the Trump administration's federal cuts to mental health care are expected to dramatically limit access to crisis centers and prevention programs, school-based initiatives, and especially harm vulnerable and low-income citizens. Cutting mental health resources will in fact wreak havoc on emergency rooms and communities that already have to carry the weight of an underfunded system. Mental health is healthcare, and defunding it only worsens public health across the country. Cutting investments in mental health care is not saving money, it's costing money. I would like to thank the Attorney General Nick Brown for suing the Department of Education for illegally cutting mental health services to students here in the state of Washington, but there's still so much work to do. Thank you so much.
Thank you, Rachel. And I'm looking again. I don't yet see Ton here, who was the other person who had signed up. So we can open it up now to attendees. If you would like to make a comment, please raise your hand. Not seeing any at the moment. We'll give it just a few more seconds if anyone else would like to make a comment. Okay, well, thank you, everyone. Thank you, Rachel. Just as a reminder, FTAC, and this is true of the commission as well, welcomes and encourages public comment. We appreciate all the feedback that we receive. It's an essential part of the process as it provides an opportunity for the public to have their voice heard at regular meetings. Public comments can be provided orally during the meeting or in written form at any time. Send it to our inbox, which is kind of a mouthful, a mouthful, and now I need to start over. HCA Universal FTAC at hca.wa.gov. Oral public comments are not accepted outside the public comment period. And now I'm going to move, I guess the next tab is mine, which is an update on the work plan. And I just want to pause. I should have said this earlier. We realized the packets went out late this time around. Our most recent commission meeting was just last week. We moved around some meetings and wound up really compressing our time frames. So thank you for your patience. We did get the full packet out to members today, this morning, and it should be posted online within the next 24 hours. So go to the next slide. A couple of things in our work plan overview. We're going to look at the tracker and how that plays into today's agenda. Look ahead to the 2026 meeting dates, and there's been an update to the FTAC charter. So the next slide. This is our key design elements that we've been marching through in the course of the year. You'll see that benefits and services has turned green, and that's because at the most recent commission meeting, the commission approved the benefits and services straw proposal. That will be incorporated into the annual report that will be submitted on November 1. Eligibility is almost done. There's a few changes being made to it. I'll talk about that more in the commission report out. So the things that are on today's agenda, later on in the commission report out, as I said, the response to the eligibility and benefits and services straw proposals. And also today, we will be looking to FTAC to dive into provider participation reimbursement, begin to frame up that conversation and put some parameters around that topic moving forward. The next slide. This one's very straightforward. It's all our meeting dates for 2026. These have been filed with the code revisor. So you should have received invitations to all of these dates. If you didn't, again, let us know. We are happy to resend them. We managed to get everything on Thursdays in the coming year, which we hope will make it a little easier for people to track. And the next slide. There was an amendment, or yes, I guess amendment is the correct word, to the FTAC charter that was adopted by the commission at the last commission meeting. And this was brought about, as Ross mentioned, David DiGiuseppe resigned his seat on FTAC. And so we looked to the FTAC charter for replacing his seat. And the sentence that you see there in the black type was all it said. Vacancies among FTAC members will be filled by the commission. And so we added to that quite a bit. This now has been adopted. The full charter, the full FTAC charter is an appendix to this packet. It just clarifies filled by the commission, announce the vacancy. We're working on the announcement to go out about the FTAC vacancy. It will be sent to all of you. It will go out through Gov delivery channels. And we also encourage you, if you have people who might be interested or networks where you want to promote this, it would be great if you could help us spread the word. The announcement has not gone out yet, but it will be going out. I don't want to overpromise on timing. I'm not exactly sure. I think within the next week or two, it should be going out. It also includes, maybe retired healthcare professionals who are no longer actively practicing. That was added by the commission as people we may want to recruit to this. So there's a lot of words on this slide, and the full thing is at the end of the packet. And so the next slide. That's the end of a very quick work plan update. I don't know if folks have any questions about it or about the order in which we're doing things. Okay, very quiet so far. You know what? The next tab is mine as well. So we have the report out of the September Universal Healthcare Commission meeting, which, as I mentioned, happened a week ago today. We had moved our August meeting to September, and then we scrunched our timing a little bit. So there's the link to the recording and to all the materials if you want to dive into it. Later, there's also some links to certain timestamps. So what I'm going to go over from that meeting is the public comment from the last meeting. There was a conversation about 1333 interstate compacts, which is a very new topic to all of us. Some feedback on the straw proposals that a work group put together and that FTAC had looked at. And also an initial discussion by the commission about transitional solutions. So the next slide. Public comment came from folks representing various organizations, Washington Community Action Network, Whole Washington, and Healthcare for All Washington. And the next slide talks more about the content of people's remarks. People expressed an appreciation for the Advocates Roundtable, which was on August 5th. And I will say also that from HCA staff and also expressed by the commission, an appreciation from the commission of the folks who showed up and participated. It was a very lively discussion. It doesn't really feel like it was last month. It kind of feels like it was longer ago than that. I think my sense of time is a little off right now. But we had worked with certain advocacy organizations. We had shared questions ahead of time. They had shared some written responses. And the conversation was great. We had a lot of people in the room. We had people from the commission. We had people from FTAC. We had members of the public. Lively enough that we did not get to all the questions. So the advocacy groups that were involved shared written responses to the pre-prepared questions. And all of those written responses are also at the end of this meeting packet. So they're also in the appendix if you want to sit down and go over those. And there's also a recording online of the entire roundtable. The other comments that came up at the last meeting were timing of the governance decisions, some recommendations for administrative simplification, looking specifically at ways to streamline prior authorization and make billing more transparent, and some support for hospital global budgeting as the payment mechanism. The next slide, we had more topics. There were some suggested changes to PEBSEB, consolidate the purchasing or expand the enrollment opportunities for local government, a suggestion to limit the health benefit exchange offerings to a standard plan, explore offering supplemental coverage for services not covered by Medicare, some more global conversations about how treatment decisions are made, opposition to AI-generated decisions related to the availability of care, and opposition decisions made by those who don't have medical licensure or experience as a provider making decisions about care. And the last one was request for input about the Washington Health Trust bill. So it was a pretty long public comment period. So thank you again to the folks. I know a lot of the folks who go to the commission also sit in on these meetings. So again, we appreciate that input. The next topic was 1333 interstate compacts. And this was a request that came in the June meeting, trying to remember when that was, June meeting. Insurance Commissioner Patty Kuderer suggested that the commission learn more about 1333 interstate compacts. And I will admit this is a brand new topic to me. I think it's a brand new topic to a whole lot of people. If you want to dive into the discussion and the introduction from the recording, these links are timestamps to Commissioner Kuderer's introduction, presentations by two subject matter experts, and then that was followed up by a Q&A and a discussion. The next slides speak at a very high level about what a 1333 interstate compact is. It's a provision of the Affordable Care Act where two or more states can create a regulatory framework to sell qualified health plans across state lines. So in order to do this, you need the approval of state legislatures and the approval of the federal government. And this discussion the commission had is the very beginning steps of learning about it. And that very beginning steps is in quote. That's actually a quote from Commissioner Kuderer, who requested in June that we bring some subject matter experts in so the commission could learn a little bit more. The next slide is something I lifted from one of the presentations because I thought it was a very good encapsulation. And it was easier just to do it this way than to try to explain it on my own. Healthcare choice compacts under the Affordable Care Act, again, permit the sale of health insurance across state lines. Interestingly, no states have done this to date, and CMS never promulgated the regulations that would guide a 1333 compact. So it's very much uncharted territory from a lot of different angles at this point. But recently, the Socio leadership has expressed some strong interest in revisiting the idea and maybe moving toward implementation and regulation. Although, again, the regulations have never been put together. So this was Jason Levitus speaking of the Urban Institute, saying it could potentially be part of a package of reforms to move toward universal coverage. There's a lot of uncertainty about how it will be implemented, and that, with uncertainty comes a certain amount of risk. So he added that under a straightforward interpretation, the Section 1333 Interstate Compact has substantial shortcomings as a tool for pursuing universal coverage. And the suggestion from Commissioner Kuderer was that as Washington explores this, Washington consider the compact with Oregon. And as you know, I don't know how to describe, I don't know what, I guess our counterpart to the commission, structured slightly different in Oregon, but with very similar goals to what our Universal Commission is doing. So that's very high level. The next couple slides talk about the ensuing discussion that came up at the commission meeting. One question was, these are more questions, I'd say, could you potentially offer a joint basic health plan? And, if you did, you could create a larger, more diverse group. There's always concern about, the size of the risk pool and the number of people, but someone noted that, Minnesota and Oregon have been able to offer BHPs and have stability. Could you potentially develop multi-state agreements around qualified health plan criteria? And the next slide is another set of questions and discussion that came up, and people were beginning to envision, well, what might this look like if we did this? And really the rules and the plan design would look a lot like the state where it originates, because it originates in one state, it follows that state's rules, and then another state agrees to it. So if you are the additional state, not the originating state, you would be abiding more by the rules and the plan of the issuing state. Also, there could be a separate exchange for selling this rather than put it on one state's exchange or another. One idea is, well, do you need a two-state exchange that's completely separate where people can buy that particular coverage? And also there are questions about the intersection of 1332 waivers and 1333 compacts. 1332 waivers and 1333 compacts, everything comes with its own set of guardrails in order to implement these things. Would the guardrails of one get in the way of the guardrails of the other? That's something to be explored that, again, not sure anyone really has a firm answer on that one yet either. So I think I have one more slide on this topic. The next steps, and then I will pause and see if folks have questions or comments on it. So what came out of the September 11th commission meeting was to explore the intersection of the 1332 waiver, 1333 interstate compacts. Do they get in each other's way? Do they complement each other? Reach out to our counterparts in Oregon. We've had conversations with them. They know that the commission had this presentation and that we've discussed this, but also, reach out again. Let them know what we think, what we've learned. And also one of the commission members brought up the point that any change or anything new, we need to make sure that we're increasing coverage and lowering cost. So that's where it landed. A whole lot of unknowns, but we wanted to give the report out of what we know to FTAC and pause and see if anyone has questions or comments about all of this. Pam.
Yeah, thank you, Mary. My question is, in the conversation, I have to say I didn't go back and look at the presentation materials, but did Patty or anyone explain what are the benefits of doing the interstate agreements? What problems will we be solving by doing these things? So these obviously, just from your description, very heavy lifts and potentially extra complexity.
Yeah, and I invite other HCA folks to jump in, or if FTAC folks are at the meeting, if you want to jump in. I think, Pam, that actually that question came up, and I think that's part of the exploration and the further looking into this. We said this is the very beginning steps where we're all learning, and I think that is still an open question. As we talk to Oregon folks and as we, figure out if the commission did not decide yes or no, we are going to do this. I think what the commission decided was we're going to explore and talk to folks a little bit more.
Mhm.
And I don't know, does anyone else want to jump in? I'm not sure that was a satisfying answer to your question.
Yeah, well, definitely with the vaccine guidance, I felt like that was really value added, with the interstate collaboration on vaccine guidance that we just saw just recently across, I think California, Oregon, Washington, and I think Hawaii also became included in that. But for this kind of on the ground operational issues, I not so much seeing the benefit. So I'm eager to hear what others might say.
Okay, thank you. Esther.
Hi, I think from a tribal perspective, this could be beneficial. So, for example, as an organization, we've actually had to establish an Alaska Medicaid contract to be able to provide service because the Tlingit and Haida tribe is like the number one tribe we actually serve. So I think if we're thinking about it from a Native perspective, it could be really helpful.
Okay, thank you.
Mhm.
And Mary, I would just add to Pam's initial question. As I understood it, in addition to the ability to sell an interstate insurance product, being able in, all of the things that come with that, larger risk pools and those types of things. And I believe part of the origins relate to the current SOCIO director writing a paper, which I believe is attached to the presentation documents from the commission that notes some creative opportunities around Section 1333. And that states could look for kind of innovative ways to use that. And my understanding is Commissioner Cooter thought that there could be some interesting opportunities for that. But I agree with Mary that we're still trying to figure out what the true benefit would be in the context of universal healthcare and the Universal Healthcare Commission. And so are trying to identify that as well and want to make sure that that's clear to both FTAC and the commission before proceeding, forward.
Thank you, Ross.
Thanks.
Oh, sorry. I don't recall if we circulated Peter Nelson's paper to FTAC. I know we circulated it to commission members. We can send it out after this meeting as well. Forgive me for not remembering who received what. But that's I think part of what has generated some renewed interest in this. Any other questions before we go on to the next topic? All right, thanks everybody. I think we have our straw proposals next, or the commission response to the straw proposals. The last FTAC meeting we had, there was a lot of input. Thank you very much to two straw proposals, one related to eligibility, one related to benefits and services. There was an in-depth work group of commission members and FTAC members, and I'm going to give a thank you to two FTAC members who are not in the room right now, who are Eddie and Roger, who are the FTAC folks who worked on it with us. And these straw proposals did a couple of things. One, they were an attempt to create a standardized format for documenting recommendations and decisions. Because sometimes, if you think about our picture with the design elements, something is green or something is yellow, and someone says, well, but what did you decide? So it's a way to try to come up with a standardized format to log decisions included in the annual report with the note that these are iterative documents that could change over time, but it's a way to establish the baseline, inform the future decisions. And we modeled this after what, again, our counterparts in Oregon are doing. So before I talk a bit about the feedback that we heard on the content of these straw proposals, I'd like to hear if FTAC thinks this structure makes sense. I mean, this is our first go round and we're trying to um, come up with a standard way of expressing things. So I don't know if anyone has any feedback on the actual process of the way we did it.
And Mary, apologies for jumping in. Just a little context too from that meeting. I think there was some from the commission side of the meeting last week, some the idea of putting forward a document that didn't have necessarily the final recommendations of FTAC and the commission, but more so as like an iterative expression of where we are right now in the conversations we've had, acknowledging that the information, the straw proposal could evolve depending on information that we learn or decisions that are made, but that being kind of part of the feedback we're hoping to get from folks if this kind of iterative written document is helpful for folks. We thought it, as opposed to like a PowerPoint, having all of that information consolidated in one document as we move through these different pieces of the work plan was helpful, but wanting to kind of stress test that and any feedback folks have just coming from that commission meeting where, that concept was maybe a little foreign to some of the commission members. Apologies, Mary, for interrupting.
Oh, well, quite all right.
Think that, Mary, I'm trying to answer the question a bit, which is, I think it's a little hard on this one because of the timing of the meetings.
Mhm.
I don't know if you feel like that had an impact too, but we can't help moving meetings sometimes, but that meant that we didn't have, there wasn't much of a catchball between the
Mhm.
two of us in terms of the reaction. So I think it seems like it has a lot of potential as a way to work together. I just think we need a little bit more of an idea of how we will hear each other's feedback.
Yep. Thank you. And I think, with the work group, they had some in-person meetings, and then we did some feedback by email because I thought, well, I don't want to overload people with meetings. And so there's always, are you better off meeting? Are you better off doing things by email? Um, so, I think we'll find the groove with that one as well. But thank you. And thank you to all the folks who provided input and provided feedback. Um, the next slide. So we did present these two proposals. Eligibility was returned for some further revision. I don't think it needs to go back to full FTAC. These are small revisions. We are working with the work group and with the commission members to make these changes. It was primarily how we chose to talk about people without permanent citizenship status. We had pulled out some text, which was an attempt to say, we understand, we're thinking about this population, um, and we've actually are working it in a different way, still mentioning it, but just talking about covering all residents regardless of citizenship status. So that's pretty much the change that came back. Um, I don't think the meat of the content changed. I think the presentation of it has changed. So we're hoping to get that into the annual report. If we can get it revised and approved at the annual report, it will go in this annual report. If not, it goes in next year's annual report. And then also the benefits services straw proposal was adopted. So that one is going into the annual report. So that's where we landed on that. And I don't know if I have another topic on this one. The next slide. I do have another topic. I seem to have a lot of slides and a lot of talking at this meeting. The last thing that the commission took up at its last meeting was talking about transitional solutions and throwing out a number of ideas of which transitional solutions they may undertake. So just, take a moment to read these. The first one is very broad. Current system identify strategies regarding federal changes like coverage losses, healthcare workforce needs in rural areas, financial underpinning to the current system, explore creation of a state option Medicare Advantage plan, and consider creating small business health options program coverage options. Ross, I don't mean to put you on the spot, but you had something to add on this for cost board, didn't you? Or am I remembering wrong?
Um, Only to say that I think all of these are consistent kind of with the cost board's overall mission of affordability and cost containment. And I believe this is a topic that came up a few meetings ago where we were trying to kind of identify where some of the transitional solutions live best. And much of this work is being done at the cost board. And I think we were trying to look for as much collaboration and symmetry as possible so that the cost board, who's already doing a lot of this work, could hopefully provide this information to the commission, and we could help each other in that way so that we don't take away from the other piece of the commission's call, which is, developing the framework for a unified financing system. So just wanted to echo that, we plan on bringing the information that relates to these transitional solutions that are being discussed at the cost board back to the commission and FTAC to highlight those as well. So just hoping to highlight the interaction between the two.
Thank you. And I don't know if any folks have any other questions or comments on this list of solutions or thoughts.
I have a comment on the last one, which is on a small business health options program. Anybody who remembers working on the exchange might have memories of this. It was a real heartbreak, I would say. And I think if the commission wants to look into it, what I would really encourage is getting the carrier point of view, because there was interest from small business, there was interest from the exchange, there was interest from providers. It was all there. Brokers loved the idea. They were very interested. The carriers did not want to participate, and we actually could not find a carrier who would be part of it. So that's a lot of it has to do with kind of idiosyncrasies of the small group market in Washington State. But that would be, if you look into this, that would be what to look at. What was nice about SHOP is, first of all, little businesses really do need other options. The businesses that can be part of associations do have lots of, have much more, availability in the market. But if you work through SHOP, it actually gives each individual, small business worker the same choices that anybody on the exchange has. So they can, even though they work for a small business, they can choose any plan. So there's a lot of really nice things about it, but it was really just impossible to implement in our state. So that would be worth looking into.
Thank you. Other comments or questions about that list?
Again, apologies for interjecting here, Mary. Just to highlight on the cost board side, on 2026, obviously subject to change and other items that are happening in the Washington healthcare landscape, but a primary focus for us is market oversight. So that's going to be done through a few different bills that were passed last year relating to the state health plan or provider registry, the OIC's primary care expenditure reporting, as well as HCA's agency request legislation that included reference-based pricing for our PEPSEB plans. So monitoring the implementation of that and updating folks, as well as pursuing some other market oversight tools to help better rein in costs and affordability. And so just to highlight that that's additional kind of transitional solutions that we hope to bring back to the commission and provide updates and solicit feedback on as well over this next year.
Thanks, Ross. Well, I'm about to jinx us in a really big way because we are really far ahead of schedule today. And so, I don't know, you probably should never say that in a meeting. And I know that our last topic, which is beginning to get our arms around provider reimbursement and participation could turn into a long discussion. So, good to have extra time for that. But we did build in a break. Do you want to take a break now? And then when we come back, we can dive into our last topic. Does that work for folks? Okay. 10 minutes? Okay, so we will be back at 2:53. All right. See everybody in a bit. Hello, everybody. Are folks back? Did we say 253 or 254? Are we ready to jump back in? All right, Ross, do you want to kick us off to
Sure.
move on?
Yes. Thank you, Mary. Welcome back, everyone. Hopefully you had a good break. We are going to now turn to tab 6 in the packet and have a discussion on provider reimbursement and participation with Mary, Christine Eibner, and Bob Murray. So looking forward to that, and I'll hand it back to you, Mary.
Thank you. Uh, Thank you, everyone. I had time to go get a cup of coffee. I think a whole bunch of us did, so I'll probably be talking faster than usual for the last topic of the afternoon. The next is we are taking up a key design element. This is the next one in the work plan and one of our priorities for 2025. So here we are, provider reimbursement and participation. Today we want to do an initial discussion, a level set, get some reactions to some hypothetical proposal. As Ross mentioned ahead of time, we worked with Christine Eibner and Bob Murray, and thank you both very much for your input. You worked also with Allie. So as I'm talking, I've done a lot of talking today. As I'm going along, please feel free to jump in with comments or anything else. I'm happy to cede the floor. I can kick us off, but please unmute yourself and jump in as you like. So our first slide is just a reference slide. The reason we are looking at this comes from the statute that established the commission. There's a reference to topics that we need to look into, and one of them is provider reimbursement and participation. This was included in the baseline report in 2022. It noted preliminary considerations, provider reimbursement and participation within that report. And also the Universal Healthcare Work Group, which is the precursor to the commission, submitted its final report to the legislature, and this topic was included there as well. The next slide. So what we hope to work on today is to discuss the potential strengths and limitations of a preliminary proposal for reimbursement, identify some key components to include in the straw proposal for provider reimbursement in a universal system. So, we talked earlier today about the straw proposal. Does the structure work? We're going to try to do it again, but this time with a new topic. So this initial discussion, these initial recommendations, this direction will be shared with the commission, feedback from the commission, and then we will continue going forward, putting together this straw proposal. And I'm blanking right now on when the straw proposal is likely to go to the commission. I know it's in the work plan. I'm guessing the December meeting. I could be wrong about that. But anyway, the next slide. A little bit of background, Washington State background. Some folks are in Washington State, some folks are not. In this past session, there's what we call the PEBSEB affordability bill has passed beginning January of 27. The PEBSEB reimbursement for licensed hospitals in Washington, reference-based pricing tied to Medicare. In network of the details, I don't need to read all of these details of what was passed, but this will be coming online in Washington in 2027. It establishes some reimbursement floors, 150% Medicaid for primary care and behavioral health services, so it's not just reference-based pricing, it actually rebalances a bit. And the fiscal note estimated a savings of more than $290 million over a 5-year period, 2025 to 2030. So I don't know if anyone else wants to jump in on the background or questions before we move on. Okay, so the next is our preliminary proposal. Ways to think through, ways to think about this. Bob or Christine, do you want to jump in and talk about this a bit as a framework?
Sure. I mean, I'd also like to hear from Christine, but I personally think the strategy that Washington has embarked on is a very good strategy to start with the governmental public and state employee program and then gradually build off of that. Um, I think one principle of reimbursement that I've learned, and having worked in Maryland for many years, is that these types of models are complicated. They're difficult to implement. You face a lot of political opposition. So it's good to after you've set up an initial program to proceed cautiously and gradually, um, because rate regulation can also do harm. I think starting with the PEB-CEP is a really good idea. And then using that model, or at least evaluating that model to see the effectiveness, both in terms of cost containment and any potential disruption to the delivery system. I'm very supportive of the strategy that Washington has embarked on initially.
And Christine?
Yeah, so I'll just add, I think, and possibly, I'm not sure if Washington has done this in setting up the PEB-CEB model, but I think it would be important to compare those rates to what providers are getting on average now, or sort of the distribution of what providers are receiving from all payers, including commercial payers. And I think that you need to look fairly carefully, right, at different types of providers to see who might be getting less, because there is a literature that suggests that, over time that could lead to adverse consequences, right? If providers decide to retire, for example, or not to settle in Washington state because of the lower rates. Similarly, it may be worthwhile to see what those rates look like in Oregon or other, nearby states, like where folks might relocate, to make sure you're not creating a situation where there's going to be an exodus of some sort.
Thank you.
I just wanted to clarify the PEB-CEB proposal. It just applies to hospitals, though. I mean, I think your point, Christine, is well taken. In other states, you've seen reimbursement levels go down for physicians. Rhode Island is a good example of that, and then they leave the state. I think just to be clear on this proposal, it just applies to hospitals, if I'm not mistaken.
Oh, right. Okay. That's a good point. I mean, but you would also need to just develop some kind of process for how you would reimburse physicians under the model.
Right. I don't think Oregon has explicitly done that. I mean, that would be sort of an add-on, and so that would be something that um, the state. And once they've done it for hospitals, did it save money? Yes. Did it disrupt the delivery system? Did it reduce care, access, and quality? No, hopefully. And then there are a series of other additional add-ons that the state could consider. One would be extending price caps to physicians and other providers, and the other would be to build out from the state-based program and potentially apply price caps, reference-based price caps to commercial market more broadly.
Are there other questions or comments as we look at this preliminary proposal?
Just on that one point, I'm glad you brought this up about physicians and other providers. The other thing that was pointed out to me, I don't think Oregon or Washington has contemplated this, but the starting with the state public and state employee program uh, has the benefit also if the state were to try to change reimbursement for physicians and other providers. In particular, in the physician realm, as many of you know, there are distortions in payments, the Medicare payment system for physicians, the resource-based payment system for physicians. It tends to over-reward specialists and specialist care and under-reward primary care and other services. So I just point out that having a PEB-CEB approach and modifying physician payment would give the state the possibility of revising its payment structure for physicians to address those distortions that Medicare has currently, and that those distortions, I characterize them as distortions, but I think they're largely because of regulatory capture by the AMA and very influential specialists. So that's another thing down the road to think about, that the state could help rebalance the physician fee schedule. But I don't want to get things too complicated at this point. Again, my recommendation is focus on hospitals, get a program in similar to what Oregon has done, and then evaluate it, and then take further steps if the state decides it's appropriate to do so.
Okay, before we move on, any comments on that approach? Okay, and also, we had a question that came in when we circulated this material among folks as we were developing these slides. We received a question about ERISA and reference-based pricing. So before we move on, Bob, I think you and Allie had an exchange where you addressed that question, and if you had thoughts you wanted to share.
Yeah, I think because it's a state program, they're not ERISA concerns. But if the state were to look at expanding, as is listed here, beyond just the governmental entity to the commercial market, I'd recommended setting price caps, reference-based price caps on hospital out-of-network rates, because that has an influences payer negotiating leverage over in-network rates. It could have a beneficial effect there. But if the state moves into setting price caps on the commercial market, there may be an ERISA concern. Although, and this is something that the state would have to investigate, and I have some folks that I'd recommend they talk to. Maybe Christine has some thoughts about this as well. Is that there was a Supreme Court case in 1996 that seemed to indicate that if the state regulatory authorities directed at what providers, in the case of Maryland, it was hospitals, can receive in payment, and the state limits that does not violate ERISA, since it's not preempted by ERISA, that it's only incidental to the costs sustained by ERISA plans, and it would not be preempted by ERISA. But again, I'm not a lawyer. I think it would be worthwhile to talk to various people. Katie Guttickson at UC Law SF and also Aaron Fuse Brown at Brown University are more expert on this topic than I am.
Okay.
So if the state's setting the rates that the providers can receive or for their services, then it should not be preempted by ERISA. Now, there may very well be an ERISA challenge, but based on the language in that Supreme Court case in 1996, which is the traveler's insurance case, it should not be preempted.
Okay, thank you. And Christine, I don't know if you had more to add.
Not on that topic, but I do wonder if anyone has done the calculation about what the average rate would be under this if the PEBSEB model were adopted across all hospitals. I'm just looking, as we're on the call, I'm looking up the RAND Hospital Price Transparency Study to look at what the average commercial rate is for Washington State relative to Medicare. And it looks like it's somewhere around 250%. That's kind of a rough estimate based on my quickly trying to average across outpatient and inpatient services. So I'm not sure that I'm getting that quite right. But it's possible that these rates would be higher on average, than what the state is currently receiving. Well, hospitals in the state are currently receiving. But I just wonder if anyone's done that calculation.
I doubt anybody's done that specific calculation for Washington, but if you look at Oregon, in their experience, the outpatient rates for hospitals were much higher than inpatient rates. The 200% cap did truncate most of the outpatient prices for hospital care for outpatient. And But for inpatient, the range was below 200 and above 200, so it truncated the highest ones. But and then part of the problem in Oregon was that the providers that were getting reimbursed less than 200% convinced the TPAs that they should come up to 200%. So there needs to be language to protect against that, and I think there is in the PEBSEB bill. So you're exactly right. I mean, there's going to be some level above that will come down, and you have to avoid the situation where prices that are below those caps come up. But overall, I think probably the outpatient side is higher than
Yeah, no,
200.
they're both higher. I'm just thinking in combination with Medicaid, although I suppose the program as initially implemented would just be for the commercial side, and then
Yeah.
Washington would transition to a global program before Medicaid was brought in.
Yeah. I think look at the sequence again. I don't mean to dominate this, but the sequence I would recommend would be, PEBSEB for hospitals, the way that they've outlined it, avoid some of the pitfalls that Oregon experienced, which I think you have language in to do that. And then consider expanding it beyond just well, if you can expand it to local governments, I think Oregon is considering that. That would bring more people into that pool. Again, it would be a government program. And then think about applying reference-based price caps to the commercial market, and see how that goes out of network, maybe other broader commercial price caps. Vermont right now has a proposal to put reference-based price caps on all commercial prices. But I think the most effective approach down the road would be to bring in all payers under a hospital global budget system. That would be more comprehensive and also help address the tendency of providers to do more volume when their prices, individual service prices, are constrained. So that was a mouthful. I'm happy to answer questions.
Yeah, I happen to know our next slide has a whole bunch of questions and considerations to try to get feedback on. So I don't know if anyone has more questions on this or more comments.
I have a question.
Mhm.
So I was wondering if, in the absence of a global budget or direct, possibly around commercial plans, is there, do we know anything about the effect of this PEBSEB type price cap on the commercial market, like negotiations among commercial, payers? Do we expect any like, you know, payers to follow just as they do with, Medicare pricing, like any impacts that we would expect like naturally without, uh, you know, explicit, state policy?
I think Oregon is the good role model there, and there's still evaluations being done on that the reference-based price cap program from the state of Oregon and their public and state employee. Um, so but so to answer your question, I don't think there's evidence as to what the hospital response has been, or definitive evidence. The preliminary evidence is what they haven't scaled back. In treating state and public employees. Whether they've reduced their quality of care is uncertain, but there's not direct evidence that that's occurred. And then the other thing to worry about is, have they tried to, quote, cost shift to commercial plans? Now they're getting less reimbursement, presumably from the state programs. Have they tried to increase the prices even more to the broader commercial market? Now, again, I don't think there's evidence to show that that's occurred, but it's a risk. So we have to, focus on Oregon and their results, and it might give you some additional information. But right now, I don't know. There's sort of a paucity of information on that.
Yep. Just to add on, during the legislative session when this bill was being debated, I had the opportunity to talk to a group of employers, some actually pretty large employers from this area. And, one would think that their big concern would be cost shifting, but instead it was more to your question, which is they were like, how can we do this too? So I think I think that it's particularly employers with market clout, they have the ability to follow rather than to be the recipient of cost shifting. And cost shifting is probably a topic for another day, but it is really interesting to say how much does it actually really occur. and what's really going on with the stories about cost shifting.
Just very quickly, it's a confusing topic. I think, in my experience negotiating with hospitals, they definitely will look to jack rates when they find that the reimbursement's being cut in other areas. Now, is it cost shifting technically or not? It could be the academic literature is that no, cost shifting doesn't really exist, it doesn't occur. But in practice, it does, on a case by case basis. But so there's that debate in the academic literature about, if cost shifting does occur, why aren't providers doing it more and more? So the conclusion is, well, no, it's not cost shifting. The hospitals just do it because they have market leverage to do it. But it does occur, and I think it's something that the state needs to be focused on and monitor.
Bob, I do have a question about this. I thought there was also evidence from Maryland. In fact, I think your study, one of your studies, maybe, that there was a volume shift. And I think there are potentially two types of volume shifts, like more hospital volume, but also shifting to the
Yeah.
non-rate set part of the
Yes.
market.
Yeah, right. So there certainly that's one of the downsides to setting individual prices for individual services, regulating price per day or price per admission, or that providers have a tendency then to make it up by doing more volume. And it's because their cost structure that if they do more volume, they can generate higher profits. So that's something to be worried about with a more focused approach like this, either setting prices per service or caps for individual prices, that you may see a volume response. So that's something to be concerned about. And that's why I recommend ultimately moving to a broader approach, more like a global budget approach, because that constrains the provider's ability to increase prices or increase volumes. So that's definitely a concern. Now, once a global budget system has been set up, if it's too rigid, then hospitals, and this occurred in Maryland, they have basically fixed budgets for each hospital. They look to shift care out into the non-regulated sector. So those are two concerns that the state must, consider. And there are ways of protecting against that. I've recommended a less rigid budget cap for hospitals in the context of the global budget. It's more of a flexible budget that adjusts for volume changes. And I can go into more detail on that. But yes, those are two concerns. They're good points.
Well, thank you all. As I said, the next slide has lots and lots of questions to dive into. Some potential strengths and limitations of this approach, which we've begun to talk about. And also, what components would you like to see included or excluded in the straw proposal for provider reimbursement and participation? Take a moment to look at this, and if things jump out at you as better ideas or ideas to be left out, that's what we want to hear.
So, I mean, just going back to the universal system. So it sounds like what we were discussing before was something more transitional, right? That would be implemented under the current system, but not necessarily in a universal system. But if we move to a universal system, I think it does have to be like much more comprehensive, so that because all providers would need to be part of the system and paid with some kind of systematic rate.
Yeah, I would agree with that, but it got to start somewhere. And I've always advocated, before you have any hope of expanding access, you've got to get a handle on cost containment.
Right.
And so Washington, Oregon have started marching in that direction, I think, effectively so far, and monitor it, see, and then incrementally move in a direction of trying to make it more comprehensive. But until you do that, the hope of a universal system is basically zero.
Yeah, I think that we're trying to respond to really a real crisis in affordability for consumers and employers.
Right.
At the same time, get a handle on costs prior to any kind of a universal system. So I think that reference pricing is a really good tool to do that. And I like what Bob said about, you kind of working, kind of incrementally marching into this better strategy for controlling costs. And I think in a universal system, you would probably look more towards global budgeting. So this is this is a nice strategy that starts, you can kind of see kind of a bright line between doing reference pricing and under our piecemeal system, but getting to global budgeting under a more universal system.
Yeah, just very briefly, I would agree with that, but I don't think you need to have a universal system to do a global budget system for hospitals. Yeah, the hopes of getting an all-payer waiver right now are very low. But you know, in 2-3 years, and this is the type of experience that states should be pursuing, exactly what Washington's doing. In 2 or 3 years, then they'll have the experience to say, okay, let's take the next step, and hopefully there's an administration be more amenable to an all-payer waiver.
Yeah, I agree with that.
So if I'm understanding this correctly, what we're talking about is the short-term, more transitional solutions, things to put in place now to test out certain models, moving toward the system that would be in place for a universal system, universal coverage. Does that sound right?
Yes.
Yes.
And does it make sense to look at those sub bullets one at a time, or do folks want to call them out, the ones that you want to include, or the ones where strong feelings?
One thing that's not on the slide that I talked to Ali about, for one, I mean, I think maybe this is a given. This approach needs to be a mandatory approach. It needs to be enforced by legislation and regulation. You can't voluntary rate setting models don't work. It also should be as comprehensive as possible, but you got to start someplace. So starting with price caps, reference-based price caps that apply to the state program is a good place to start, then building out from there. So this first one, recommendation about fees and rate setting mechanisms for enforcement, you already have basically a mechanism for enforcement under the PEB-CEP bill. And the rate setting structure is price caps, reference-based price caps. It applies to hospitals, so you basically answered that for at least this preliminary model. The incentives are for provider, participation is you mandate provider participation in essence. And if the hospitals don't participate, they get a lower fee. You have in and out of network rates at 200% and something lower for out of network. I think it's 185, at least in Oregon, it was 185% of Medicare. Then these other things you can't achieve overnight, but you look to try to do things like improve the equity of pricing over time across all services, because prices have become distorted from one service to another over time because of lack of regulation and the vagaries of payer and provider negotiation. But over time, if you had a more global system, you could try to address these other issues like equity or financial performance and stability. But I think the other thing is, as you move to a broader system, you also have to think about a governance structure that would work for like a global budget system. One of the weaknesses of the original Hospital Cost Containment Commission was that they were not effective in battling regulatory capture and regulatory failure. And you can address some of those issues by creating a governance structure that is more immune to those issues. So that, again, that's a lot to digest, but I think some of these things have already been addressed, at least preliminarily in the PEB-CEP bill. And then as you get a broader system, you can start to add in thoughts and priorities.
So for the first go round of, we're framing up these recommendations that, we want to take this to the commission for them to consider it. Does it make sense to have very big, broad goals? Things, so I'm looking at the things that are toward the bottom of the list. Things like, equity and prices in the system over time, correcting for distortions in the pricing system, thinking about governance structure, saying, okay, these are the things that make up our long-term goals. That's our long-term vision. But in the meantime, we want to take these smaller steps, more incremental things that, may become part of the universal design. It may not, but we think in the meantime, this will improve things. And that is where we talk more specifically about the mechanisms that FTAC is recommending. Did that just make sense the way I framed that up?
I think the recommendation to really articulate the broad ultimate goals related to a rate setting model is very important. In Maryland, we had from the beginning, we had a list of 5 or 6 goals that were like mantras. We would repeat them each and every meeting we had, and any sort of recommendation that we'd kind of for a change in the model or the rate setting methodology, we'd kind of run that by those key goals, and they were cost containment, expansion of access or improvement of access, improved equity in pricing and equity, just fairness in terms of how the system operated, accountability of hospitals to the public, and accountability of the rate setting commission to meet its actual policy goals, and improved quality and effectiveness. Those 6 goals. Oh, and then also improved financial stability and predictability for the providers. So it's kind of, dealing with both sides of this equation, the public side and also the private side, and make sure that hospitals have a predictable approach that they can take and they can respond to the incentives. So I do think it's worthwhile to have something similar, like 5 or 6 goals, overall goals that you want to achieve through this reimbursement system.
Okay.
And you've listed some of them here, but I think you can add to that, is my
As I
point.
say, any reactions to structuring it that way?
Yeah, I think it makes sense. What I wanted to ask, maybe this is for staff, is because we do have a cost commission. Have they set goals? Do they have like a set of goals that we should look at?
I'm going to bump that one to Ross, who knows the commission a lot better than I do. Is Ross here?
Yes.
There we go.
And the question was, is there a like overarching set of guidelines or goals that guides this? Apologies if
For the
I
cost
was-
board.
Yeah,
For the cost board.
because we were talking about, Bob was talking about setting a set of goals to be part of this, part of the straw proposal or whatever we're putting forward. And then I asked if the cost commission already had a set of goals or something that we should try to coordinate with or take a look at.
No, there's not, at least to my knowledge, and I apologize if I'm failing to recall. We do have some visuals that we can maybe circulate after this that kind of points to our different legislative calls. But in terms of actually like a set of guidelines that we kind of work through when determining priorities or impacts, I don't believe we do have that outside of kind of prioritizing affordability in our discussions. But perhaps that's something that I can bring to the cost board as a really nice idea to maybe help again kind of synchronize the commission and FTAC and the cost board. So thank you for that.
Thanks. Okay, so it sounds as though, I'm thinking synthesizing everything we've heard, getting things out to people, hearing people's responses, so that we have something to go to the commission. Kind of thinking through all of that, it sounds as though staff should develop some or draft some overriding principles, some, guiding principles, vision, I don't know what we want to call it, and circulate that among FTAC to make sure there's agreement, to get people's feedback on that, just to make sure we're all heading in the right direction or the same direction. Well, same and right direction. We want to do both. And then from there, also develop what we're thinking of as the more specific proposals. And so, can we go back to the previous slide? Is this the basic structure of the preliminary proposal that we want to work from?
Yeah, cheers.
And I'm not saying this is verbatim set in stone. I'm saying this is what staff takes back to develop to circulate to people, not asking for a final decision right now, just asking, is this our direction?
Yes, I think it is. I mean, you could add more to these sub bullets, but yeah, I think it just outlines the basic approach that should be effective. Yes, and that the state should follow. And this is more or less the proposal that Oregon has adopted.
And sorry, just for clarification,
Mhm.
for this being this sort of like basic structure, what's implied here is that we're starting with hospital prices first, one, and two, a reference-based price cap, right?
Yeah.
Like as opposed to the following slide, which is more broad about hospitals and physicians and other providers, right? Okay.
Yeah, that is what this is saying.
Yeah.
And is that the approach that people want to take?
I also want to just ask a clarification about like who this applies to. And yeah, I see the expansion, but I'm not sure, are we starting just with PEB-SEB and then what's the sort of timeline for expanding that out to different sectors?
So that would have to be determined. I mean, I just think you can just make it up. First 2 years, just PEB-SEB, price caps for hospitals, monitor the changes in delivery systems, see if there are any unintended consequences as a result of that. And then if not, year three, look at the potential expansions, like adding in all local governments into this price cap program. Again, it's a government program and there are no ERISA issues. And then if that in year three, four seems to be working reasonably well, then consider expanding into the commercial market and trying to garner support from the employers. And if they're interested having this model extended to the commercial market more broadly, so much the better. That's great. But I would start with out-of-network prices first and monitor that and then consider expanding it to all commercial. Although I think at that point, you might want to jump to something more like a global budget type of system, apply for a waiver, and then just focus on hospitals. Again, I think the hospital sectors should be the target because that's the largest sector of providers, and that's really where I think the biggest affordability issues are. But you could, with conversations with folks on the Cost Commission and us and the Universal Healthcare Commission, you can map out a 2 or 3 or 4 year strategy in terms of how these things are rolled out.
I don't know if folks want to see this slide or the next one. I don't know what's easier to think through.
I think on the first one, Mary, I think is just that I think there's a evolving consensus around that one. Is that if that's what you're looking for?
Mhm.
I don't know, Christine, if you had comments about the time frame or wanting to see more of a time frame in there, or just wanting to understand if there'd been any thinking about that.
No, I mainly wanted to understand what we were starting with.
Yeah.
Yeah.
Yeah. I don't know if it's mentioned. Bob has brought up the out of network, policy idea or stream of thinking. So I don't know if that's captured, but I think that's that would be an important element to work on. I think that's more of a transitional idea, but I think it would be important.
And just to be specific, the out-of-network legislation that I would recommend would be applicable to commercial insurers.
Yeah.
And so it would be a big step to move into the commercial market. You're going to get a lot more pushback from the hospitals because they know exactly the dynamic, which is that they go in their negotiations to the payer and they say, you get to give me my 10% rate increase or I'm going out of network and I'm going to charge you full charges. And it's going to cost you more and I'm getting more revenue. And if you take away that option, then the commercial insurers basically can negotiate rates very close to that out-of-network cap.
Mhm.
And they know it. So
Right.
so be prepared for a big pushback. So
Yeah, maybe, but if it's successful, you fix something that I think is currently broken in our
yes,
system. Yeah.
yeah, right. And it also will address, I think, big issues in the No Surprises Act,
Right.
which is, you've got this administrative process, which it doesn't work and largely have ruled in favor of the providers. And so you're just setting a reference-based price cap, and there's, little argument about it.
Mhm.
And I just want to pause for a second. Vicky Lowe, Chair of the Commission, has joined us. I seem to be putting a lot of people on the spot in this meeting. So, Vicky, is there anything from the Commission's point of view that you think should be included or should be considered, or anything you want to add?
I'm just really enjoying this conversation. It feels very positive and forward thinking. And I'm taking lots of notes. I know that, we had the straw proposals at our last meeting. I think, did you guys already do the meeting summary, Mary?
Yep.
Okay.
I
Sorry.
don't know if there's anything you want to add. I talked about straw proposals, 1333, transitional solutions, and I think the public comment.
Yeah.
Not in that order.
No, just thank you guys so much for the work you're doing. I can start to like really visualize something moving forward. And I think in this time, we need something positive to focus on. So yeah, just really thank you all. Just trying to take it all in. So I appreciate the time to listen.
Thank you.
I have a lot of thoughts, but you guys are having better conversations, so I'll be quiet.
And Christine.
Yeah, I realize I have a question for Bob about sort of the combination of the reference-based pricing with with these rates. Are you suggesting, could providers balance bill over and above the rate that's set? Like, where does the balance billing come in the reference pricing? Is that like then the lowest rate you can balance bill up to 200%, or like how would you envision that occurring?
Well, I think there would need to be either that or a prohibition on balance billing. Well, so maybe that's one and the same. But I think you can't balance bill above whatever so if you were to set an out-of-network price cap of 185% of Medicare, then that's the price that the hospital gets. They can't balance bill.
But you were talking about reference pricing as part of this. I thought maybe I misunderstood what you'd
Yeah,
said.
well, but so you set a rate at 185%, you're referencing 185% of what Medicare would have paid for that amount. Let's say, it's $1,000 charge, so now they can't charge more than 850. That's the price they get, and they can't balance bill above that, if that makes sense. So you're combining reference-based pricing in the context of out of network. You're setting price caps just like you did for all services for PEB and SEB,
Okay.
if that's clear.
And Kai, did you want to add a comment?
Yeah, so I think this preliminary proposal makes sense as a starting point. I was also though pondering the point on the following slide about pricing equity and the impacts of this like increased coverage, right, overall on primary care and primary care access, right, and primary care providers, right? Like if there's an increase in volume, right, of individuals who are covered and primary care supply is constrained, right? Supply constrained. Like, how would that impact access? And I wonder what is the right timing for some primary care, supply incentives, right? Like, pricing equity, things like that. I guess certainly like, on this side, like the preliminary proposal might help with, helping with the budget side so that can happen for pricing equity for primary care.
Well, so I mean, it's a very good question. It's a little bit complicated question, but so again, my recommendation or what we've talked about here is start with PEB/SEB, start with capping prices for that program for hospitals, monitor that over time, then you expand to local governments, the price cap program. Consider also adjusting the physician fee schedule to address some of the inequities. I think this gets to your point, between specialist reimbursement and primary care reimbursement. And I think the state would have the authority in the context of their PEB/SEB program or local governments to do that, to rebalance rates so that primary care physicians are getting paid more and to address the issues that you mentioned, expanded access and more people in the system. So you can consider staging it in that way. And that's why I mentioned this, trying to address the distortions in the physician fee schedule as something that could be done within the context of PEB/SEB, because I think it's a positive policy change, and it kind of gets to your question, and trying to reimburse primary care physicians more fairly.
Thank you. I don't know if there are other questions or comments. I'm wondering, for FTAC members diving into this, learning more, figuring out, what the recommendation would be, is there information or speakers or, a direction staff can help with? I don't know if we want to invite speakers to a meeting or if, looking more closely at Oregon or a speaker from Oregon or something. I don't know. I'm spinning ideas out of my head, but I don't know if there's anything that would help that we could maybe look at for our next meeting or for circulating information.
I could recommend some folks depending upon the topic. I think overall, with the topic of reference-based pricing, price caps, the folks from Brown have a lot of experience with that. Both my daughter Roz Murray and also Chris Whaley, who's done a lot of work in price transparency, and authored some reports that really emphasize the effectiveness of rate setting over other types of policy interventions like price transparency or antitrust enforcement. So those would be, two people you might consider bringing in. On the primary care side and physician reimbursement side, Bob Berenson is a really good person to consider, talking about rebalancing rates across providers and addressing the distortions. He's been a very vocal critic of the reimbursement, the RUC, which is the committee that sets reimbursement for Medicare for physicians, and could provide some thoughts and insights about how the state might approach rebalancing things, based on Kai's comments and observations, which I think are very good ones. So those are two folks in particular, or two sets of folks that you might consider. On the ERISA front, I would consider maybe also contacting somebody at Brown, Aaron Fuse Brown, who is a lawyer and knows a lot about that issue. So it just depends upon how you want to stage this.
Yeah, I think, Mary, I was going to add to that a small thing because I love what Bob just went through. It would be very helpful, although it's a lot to cover. I don't know if we would need to kind of do some level setting on the reference pricing bill that passed our legislature last year and that Healthcare Authority is currently implementing. I don't think like any legislation, I don't think it went through in its completely idealized design that it started with. I know there were compromises that were made along the way, but it might be helpful for people to understand that because in many ways that's kind of our starting point here is from that bill.
Good idea. Yeah, thank you. That also is a good idea, and we could, tap into the HCA people who are doing the rule writing right now.
Right. Some of them are probably in the room, right?
Exactly. Yeah.
Yeah.
Excuse me. We know where to find those people pretty easily. Excuse me. You're all putting up with my cough this afternoon. So I think what makes sense, and I don't want to cut off the conversation. I'm going to throw out an idea and then, please keep going if we have more, is for staff to take back what we heard today, which is a lot, distill it down, and then circulate something among FTAC members that talks about, the big broad goals, this is all draft, and then talks about, the specific steps, the incremental steps that we might take, the recommendations that might be made. I don't know how specific we want to get with the recommendations. You always sort of have to walk this line between big, broad ideas and super specific. I think if we go back and forth, we can figure out where that correct path is. Also consider future speakers, future topics, including maybe the level set of the PEB/CEB bill that is, in the process of being implemented, and maybe also draw some lessons from Oregon. And then as we go back and forth and we're, coming up with our big, broad topics and then also our more specific things, if questions come up and we need more information or people want to dive in a little deeper, then Bob, I think the folks you mentioned on the specific topics might be the place to go next. Does that sound like a good plan to folks?
Yes.
Yeah, I'm not
Yeah.
hearing any no's.
Yeah. I agree. Sorry, I was struggling to
No,
unmute
no,
myself.
quite all right. I just think, it's a lot, and we sort of said, hey, here's this huge topic. Where do you want to go with it?
Yeah.
So very happy with the direction things have gone today, and the guidance is really helpful to begin to frame this up. This is just another big, broad topic that isn't easy. So thank you all, and I don't want to cut anybody off. Does anyone have more comments or questions or comments on what I just proposed?
I agree with Pam. At level setting on the PEB/CEB bill is probably the place to start.
Okay.
And then you can think about, all right, once you've done that, and perhaps working with the Cost Commission, establish a set of principles and goals, at least overall principles and goals, then you can dig down into some of these more nitty-gritty operational issues.
Okay.
Just one
sorry,
additional question. Apologies, Mary. I was wondering what, if any, consideration or thought should be included in that staff work related to kind of the current economic environment, healthcare market. The PEB/CEB bill was passed maybe before some of these direct impacts are starting to be felt, and we're certainly seeing them in our preliminary results from the data call that the cost board does. And I know that that's a topic of conversation going on the cost board side. So wondering if that factors in at all, or if that's a little too perspective at this time to start, frankly, sort of guessing at some of the impacts. But I'd be remiss if I didn't bring it up, as I know that that is certainly a factor impacting, affordability and cost containment currently.
Yeah, I think that's a really good idea to really anticipate what's coming down the pike in terms of the coverage reductions, both in Medicaid and also in the broader commercial market, because that's going to put a lot more pressure, obviously, in terms on the revenue that hospitals and other providers are going to be able to generate, and it will generate more uncompensated care and bad debt. Now, just on that topic, a broader system like a global budget system, one of the goals, is access. A sub goal there would be through a broad, all-payer global budget system. Is there a way of financing hospital uncompensated care broadly and fairly in that system to try to address the financial constraints that hospitals are going to face as a result of those coverage cutbacks? And that's one additional goal or objective that can be achieved by a broader system. You can finance uncompensated care. Maryland did that for decades. It was very effective. So something to, again, you're peeling away the onion here. You get to these different things, but I think it's a very good thing to consider.
Thank you,
Thank
Bob.
you.
Yeah, I think that's a good catch, Ross, because we seem a little tone deaf if we kind of go marching forward without paying attention to the current environment.
Yeah, and another point that kind of relates to the current environment is that obviously small rural hospitals are struggling, as well as inner city hospitals, and then partly related to cutbacks and coverage and everything, but just generally reimbursement. They don't have the leverage to negotiate much higher rates. So this idea of rebalancing payments to make the system more equitable and supporting struggling, needed providers is something that could be achieved in a broader system as well. So that's part of this, one of the goals about financial stability and predictability for hospitals. And so with each of these goals, you can kind of enumerate, okay, here's what we're trying to achieve by this goal, cost containment. Here's what we're trying to achieve by access. Here's what we're trying to achieve by improved effectiveness, and identify the types of mechanisms within a broader payment system, like a global budget system, that could be achieved by the state. So it shows that the state is sensitive to the challenges and the needs that providers are facing, and we're all in this together. So we're trying to make an overall better healthcare system for everyone.
I love that, Bob. I love that harmonizing idea. So that's great. Thank you.
Thanks, Ross. All right, we may be, I guess I didn't jinx us too bad because I think we may be about to wrap up unless there's more comments, more questions, more direction to add. All right, well, I'm just going to say thank you, thank you, thank you. This was all incredibly helpful. Staff will take this back and we promise to turn this into something more digestible and circulated and work on getting the speakers for next time. So appreciate everyone's input and conversation. And Ross, I think I'm supposed to turn it back to you to officially adjourn.
Thank you, Mary. And again, thank you so much for everyone in attendance today, in particular the FTech members, for this really fantastic discussion. We will summarize this discussion at the October Universal Commission meeting. Just a reminder, the next FTAC meeting is Thursday, November 6th, the same time, 2 to 4:30 p.m., and we look forward to seeing you there. Again, just wanted to apologize for the packet being a little late this time. We hopefully will avoid having commission meeting right before a FTAC meeting in the future. So again, apologies for that. The meeting materials are posted online, or they will be very shortly, for anyone who needs access to those, as well as a recording will be posted in the near future as well. So again, apologies for that, and thank you for working with us on that. And thank you again for everyone's participation today. The meeting is adjourned at 3:50, and hope everyone has a wonderful rest of the day and rest of the week.
Thank you,
Thank you all.
everyone.
Thank you.
Bye-bye.